the pain still not relieved. And during this time, patient also developed nausea and vomiting, about 1 to 2 episodes per day after eating meals. And the vomitus contains food and fluid. However, no blood or bilious noted. One day prior to admission, patient claimed the pain become more frequent and lasting longer, about 1 hour per episode, and the vomiting still persists, which prompted her to seek second opinion at ED Susmed. And throughout this onset of illness, patient claim also associated with loss of appetite, about only able to take 6 spoons of bubur for meal compared to a normal meal, and also a lethargy. Otherwise, no fever, no yellowish discoloration, or no obstructive jaundice symptom, no significant weight loss, no history of dyspepsia, no dysphagia or early satiety, no diarrhea, or no cystaturia. Upon further questioning, the patient claimed she had a history of taking oral contraceptive pill for 3 years after last childbirth about 16 years ago, and had history of taking traditional medication for 2 years, however stopped 3 years ago. Her diet usually consists of fried food, but however, patient also claimed to have high in fiber intake. She claimed she usually live a sedentary lifestyle. However, no smoker, no alcoholic intake, no history of endoscopic procedure, no previous history of gallstone disease, no previous history of blood transfusion. Systemic review was unremarkable. For she has no comorbidities, no previous history of surgical procedure or previous hospitalization, no family history of gallstone disease, blood disorder or malignancy. For social history, the patient is a housewife, married to an ex-husband, blessed with 4 children, a non-smoker, denies alcohol intake or any high-risk behavior. Physical examination was done for this patient at second day of admission. On general examination, the patient is a medium Malay lady, lying comfortably in supine position under room air. Patient is clinically pink, not in pain. There's banula attached at the left dorsal with no active infusion at that time. No injection or scratch mark noted at the peripheries. Eye shows scleral itis. Throughout the examination, vital signs were normal. On abdominal examination, no distension, no scars or scratch mark noted. Abdomen was soft and non-tender. Murphy sign was negative. No palpable gallbladder, no hepato or splenomegaly. Shifting downwards was negative, and normal bowel sound was heard. And rectal examination shows the patient have brown stool. In summary, my patient, 1M, a 47 years old Malay lady, no medical illness, come in view of epigastric pain for 2 weeks duration associated with jaundice. However, no fever, no other obstructive jaundice symptom, no abdominal tenderness, and Murphy sign was negative. For this patient, my provisional diagnosis would be obstructive jaundice secondary to cholelithiasis as evidence of the epigastric pain, jaundice, and the patient is afebrile. However, my differential would include gallstone pancreatitis because of the onset of the patient experienced severe pain, epigastric pain radiates to the back, and also the jaundice and nausea or vomiting. For other differential would be acute hepatitis. However, there's no history of suggestive hepatitis from this patient. Ascending cholecystitis, however, patient deny any fever, and the vital signs show the patient is afebrile. Okay, for the investigation, ideally we look for the liver function test for blood count, serum amylase, for gallstone disease. But we need to send for serum amylase to exclude pancreatitis, and to rule out the hepatitis part, we send coagulation profile hepatitis screening. For this patient, after her blood result shows the liver function test has elevated deranged liver enzyme with raised bilirubin, which more towards direct bilirubin. However, her other parameters were normal. For ultrasound hepatobiliary, ideally we send it to visualize the liver, the gallbladder, if there's any evidence of gallstones, wall thickening, or pericholecystic fluid, or any dilatation of CBD, and any pancreas abnormality. So in this patient, the liver was normal, the gallbladder was distended, but no stone or wall thickening or pericholecystic fluid noted. However, the a normal pancreas, or the finding for this patient, there's a stone at the distal CBD about 1.1 cm, and with common bile duct is dilated about 0.7 cm. From this current impression, the patient have cholelithiasis that causing the biliary tree obstruction. Okay, for the management, as the patient still claim still having pain, pain management was given for this patient. Specifically was given IV tramadol. And for the investigation, for the management, patient was done endoscopic retrograde pancreatography (ERCP) for diagnostic and therapeutic, for better visualization of the biliary tree and pancreas, and for the therapeutic part, for this patient, sphincterotomy and gallstone removal was done, and her finding of ARCP shows there's multiple stone at the mid CBD and able to complete clearance of the stones. And for definitive treatment for this patient, ideally is elective laparoscopic cholecystectomy to prevent the recurrence of cholelithiasis. However, the patient still unsure of her decision up until discharge. That's all from me. I will pass to my other colleagues.
Okay, Assalamualaikum everyone. My name is Uzma. So I'll be talking about the anatomy and physiology of gallbladder for the first part of my presentation. Alright, so actually I've already presented this during our seminar with Prof. June last time. So this is like a recap of what I already presented. So the gallbladder is a pear-shaped organ. It's located at the right upper quadrant of the abdomen. It is measured approximately 10 times 4 cm. Even though it is a small organ, it is a common cause of abdominal pain because of the gallstones. So anatomically, it is located anteriorly on the undersurface of the liver segment between liver segment of 4 and 5. And as you can see, it is divided into fundus, body, and neck. So the gallbladder fundus is wide over there, and it is continuous to the main body, and then tapers down to the infundibulum and connects to the neck and the cystic duct. So we also have the Hartmann's pouch, which is the outpouching, the inferior outpouching of the gallbladder of the infundibulum. And then we have the biliary tree, which is we have the left and right hepatic ducts that joins to from the liver to form the common hepatic duct, and then it will exit. It will join the cystic duct. Will join the cystic duct and form the common bile duct. So if there is any dilatation of that duct, it indicates usually distal obstruction. It can be from the common bile duct stone, any benign stricture, any neoplasm, or from the bile duct or the pancreatic head, or the ampulla obvator. So, okay, next. Okay. Other than the general anatomy just now, there is another anatomy that is important clinically is called the callus triangle. So basically, it's a small, like a triangle and anatomical space in the abdomen. Is located in the porta at the porta hepatis of the liver. So the porta hepatis is where the hepatic ducts and the neurovascular structures that enter and exit the liver, basically. So this triangle space is dissected during cholecystectomy. So to identify the cystic artery and the cystic duct before any ligation or any division. The boundaries, we have medially the common hepatic duct, laterally the cystic duct, superiorly the inferior surface of the liver. And then the contents, which we have to avoid we have to take note of. The contents are usually the right hepatic artery, cystic artery, the lymph node of Lund, which is the first lymph node of the gallbladder, and lymphatics. Okay, next. All right, so for the physiology of gallbladder, so as we know, the liver secretes bile continuously, right? And it may produce up to 1 liter per day. So it will pass along the biliary tract into the gallbladder, where it is stored temporarily. However, the main function of gallbladder is actually to concentrate the bile. So in the gallbladder, the bile can be concentrated as much as 10 times. This is by a process of the mucosal reabsorption of the water. So when we eat and the food will be broken down, there is the chyme that will pass down through the small intestine, right? And firstly in the duodenum. So when that happens, there is the cells called eye cells that is located in the endocrine cell of the duodenal mucosal, the duodenum, the mucosal lining, and it will create cholecystokinin, the CCK, into the bloodstream. So this is the hormone that will contract the gallbladder, and it will squeeze the bile into the duodenum. And the bile will be the concentrated bile will be released into the common bile duct. So this bile salts, it acts as an emulsifying agent. So this will help the absorption and the digestion of the lipid. So if there is any obstruction, any biliary tract obstruction that prevents the bile from reaching the duodenum, the lipid will not be digested or absorbed. So this can result in the full smelling, the fatty stool, as we know, steatorrhea. So in summary, the gallbladder, it will empty the storage of the concentrated bile into the duodenum, mainly due to the response of the CCK, the cholecystokinin stimulus, that is initiated by fatty foods. Okay, all right, next. All right, so next I'll be talking about gallstone disease. Okay, so just introduction of the gallstone disease. Gallstone disease can be known as cholelithiasis, cholelithiasis, when the stones are present in the bile ducts. So usually most of the if the gallstone is symptomatic, it can present with pain, usually located at the epigastrium or the right hypochondrium. And then the characteristic of the pain, it varies, but usually it's acute and intermittent in nature. So gallstones are actually rare before adulthood, and it increases their prevalence with age. So the older you are, there is a higher risk. However, I wasn't actually able to find any data on the gallstone in Malaysia, but in Europe, the mean prevalence is about 10 to 15%, and about 80% of it is asymptomatic. And about 1 to 2% will develop complications that require surgery. In general, women are 4 times more affected than male. And one of the reasons for this is the pregnancy. It is one of the important predisposing factors as well. There are different types of stones. Majority of it is mixed. So what mixed means is that there are different constituents of stones, which can either be cholesterol or any pigment stones inside these mixed stones. Um, mixed stones actually, most of the constituents of mixed stones are actually cholesterol stones. Um, Next is cholesterol stone, which is about 10%, and then the rest of it is pigment stones. Okay. So how does these gallstones occur? So the main factors of gallstone formation is actually these three. Firstly is the changes in concentration of the constituents of bile. As we know, bile, it constitutes with different compositions, right? So if there is any of these that are in imbalance, it can um, it can it can contribute to the formation of it. For example, if there is excess of the cholesterol in proportion to the bile salts, this can lead to cholesterol stone formation. Next is biliary stasis. It can like precipitate the form of bile. Okay, there are different causes. So, for example, if the gallbladder becomes obstructed, or the contractility of the gallbladder, so the gallbladder is unable to contract the bile, becomes defective. So it can also contribute to the gallbladder biliary stasis. Next is infection. So actually, inflammation and infection plays a role in gallstone formation. So uh, if there is any abnormality in the bile composition in the bile composition, as I said just now, it can cause inflammation of the gallbladder. So this inflammation of the gallbladder, it can leads to inflammatory debris and exudates. And then bacteria can also accumulate where the gallstones are built. So when there is a defective emptying mechanism, as in there is the gallbladder is not properly emptying these accumulations, then it can also lead to the gallstone formation. All right, next. So what are the risk factors? I've uh, I've divided it into the different types of stones to make it easier to understand. So as I said just now, cholesterol stones is the majority of the stones are cholesterol stones. Okay. For cholesterol stones, there is abnormality in the bile constituents. It can either be due to cholesterol supersaturation or decreased gallbladder emptying. So for cholesterol supersaturations, that means that there are more cholesterol compared to the other composition. So um, as we know in the textbook, what is usually mentioned is that there is the saying of the fat female, fertile, and 40. So fat means obesity or any metabolic syndrome, such as dyslipidemia type 2 DM. And then female is the female gender, fertile as in the pregnancy, and the 40 means the increasing in age. So that is just for us to remember it easily. Yeah, so if you look below the metabolic syndrome, there is a table below there um, for the dietary factors. How does this actually contributes? Because if the high caloric diets, high refined carbohydrate diets, or generally obesity as well, it will enhance the cholesterol synthesis. So more cholesterol production and secretion. So obviously it can has a higher risk of the cholesterol supersaturation. And then gallbladder stasis is what I mentioned just now. Gallbladder stasis, it is basically the gallbladder hypomotility. So such as spinal cord injury, prolonged fasting, and total parenteral nutrition can cause this. Uh, in spinal cord injury, there is gallbladder stasis, and also there's also metabolic changes that can lead to abnormality in the biliary lipid secretion. So this can contribute to to the gallstone formation. For prolonged fasting and TPN, actually gallstone is a common complication of TPN. Is due to the biliary stasis because of the lack of the antral stimulation. So this prolonged fasting and TPN, it prevents the normal stimulation of gallbladder activity because like for prolonged fasting we're not eating, so there is lack of the stimulation. So next is the hormonal factors. We have pregnancy, contraceptive pill, or estrogen replacement therapy. So for during pregnancy, actually the pregnancy involves both the changes in bile composition and the late gallbladder emptying, which is the gallbladder stasis. Both it will promote the stone formation. And then next is the lifestyle factors. We have the sedentary lifestyle and rapid weight loss. There are studies show that gallstone formation is associated with weight loss, with rapid weight loss. That means patients that eat less than, that have diet less than 800 kilocalories per day. So what is recommended is that weight loss should not exceed 1.5 kg per week, or if the patient undergo gastric bypass. Next is medication such as fibrates. Fibrates is used in the treatment of this dyslipidemia. It can result in the cholesterol supersaturation of the bile. So we have pigment stones next. We have brown pigment stones and black pigment stones. For brown pigment is mainly due to the infection. So brown pigments infection. Okay, so we have increase in deconjugated of bilirubin glucuronides. We have because of the infection, there is bacterial degradation of the biliary lipids, and this degradation, the products, it will precipitate as calcium bilirubinate. And then we have black pigment stones. Black pigment stones is due to increased bilirubin secretion. So anything, if we just think of like increased bilirubin secretion, we can think of different types of causes, such as like diseases that can cause chronic hemolysis, such as this D6PD deficiency, any cirrhosis, increase in that can cause increased bilirubin secretion, inefficient erythropoiesis, and Crohn's disease. Crohn's disease is because there is altered in the enterohepatic cycling of the bilirubin. So this can increase the bilirubin secretion as well. All right, next. So I will talk one by one of the different types of stones. Firstly is the cholesterol gallstones. Cholesterol gallstones, it can be divided into the mixed stones and the pure stones. So mixed stones means that, as I said just now, mixed stones are basically, there are different types of stones inside the mixed stones. However, cholesterol is the one that is the predominant constituents. So these mixed stones accounts about 80% of all gallstones. And we also have pure cholesterol stones. Pure cholesterol stones are about 10% of all gallstones. So on the first picture in the middle there, you can see that that is the picture of a pure cholesterol stones. They are yellowish in color, large, smooth, and usually the shape is egg or barrel shape. Usually they come out solitary, so one by one, with it's called cholesterol solitaire. This the pure cholesterol stones, they are radiolucent. And then we have the mixed stones on the right hand side. Usually because they are mixed, there are different, there are multiple stones that comes out, and they are from different generations, as in they are gallstones that are produced at different times. There are also different sizes, with the shape ranging from it can be faceted or irregular shape, and then the color also ranges. It can be yellow because of the cholesterol stones, and it can range into green to black. So for mixed stones, majority of it is radiolucent, only 10% of it is radio opaque. Okay, next. And then next is the pigment stones. So pigment stones is I'll be talking about the one on the left side. So you can see it's brown in color, and both of these pigment stones are actually radio opaque. So the brown pigment stones, as I said just now, I've talked about the risk factors and the cause of it. So it is due to infection, and usually it's soft. The formation is due to infection of the because of the bacterial degradation of the biliary lipids, and then also biliary stasis is another factor. On the right hand side is the black pigment stones, which is also radio opaque. It is the consistency is hard and brittle, and the formation is due to increased bilirubin secretion into the bile, as I've also mentioned previously. Okay. Okay. I think that's all for me. Thank you.
Okay, Assalamualaikum warahmatullahi wabarakatuh. I'm Amina Abdulrahman. Me and my colleague will be explaining about several differential diagnoses for symptomatic gallstones. So as we know, gallstones, like Uzma explained just now, they can be asymptomatic, or they may cause vague, long, chronic symptoms. But in certain conditions where there are several acute pathologies, they can cause, they can present acutely. So as we go along this discussion, you will notice that these diseases can be like a spectrum of gallstone disease. Okay. Next slide. Okay, next slide. Okay, so usually gallstones can be asymptomatic, but when they do present with symptoms, the most common reason is due to the bile duct obstruction, usually the cystic duct, and this can cause severe pain. Okay, so in biliary colic, the clinical features are usually severe right upper quadrant pain, which rises to a plateau over a few minutes and then is persistent for a few hours. That's why biliary colic is not a true colic, because the pain is constant after it plateaus. Associated symptoms would be like anorexia, nausea, and vomiting. And typically, there will be a history of eating a large fatty meal. Okay, and on physical examination, usually the only signs are like local tenderness at the right upper quadrant due to the distended gallbladder. Okay, so in biliary colic, the pain usually resolves spontaneously after a few hours, meaning that either the stone has passed through the common bile duct into the duodenum, or it has fallen back into the gallbladder. But if the pain persists, then we need to suspect other pathology. So in investigations, the most important would be full blood count and liver function test. Full blood count is to exclude elevated white cell count, which might indicate acute cholecystitis or cholangitis as a better differential. And liver function test, there might be elevated liver enzymes. So the first line investigation is usually imaging investigation, is transabdominal ultrasound, and this should be performed early, since if we can establish that there are biliary gallstone biliary obstruction, then this will save the patient from prolonged hospital stay. So in most cases of biliary colic, when the patient already knows the diagnosis, it can even be managed at home, because the main management is to relieve the pain. So in the hospital, patients usually require opioid analgesia because the pain is quite severe, and they while waiting for the operation, they usually are put on a low-fat diet to minimize the symptoms, and monitored for complications. So the definitive treatment in biliary colic is cholecystectomy, and more and more surgeons are starting to prefer early cholecystectomy, because yeah, you don't have to do cholecystectomy, but more and more they're starting to prefer it, because if you delay the cholecystectomy and complications occur, then that's we want to prevent that. Okay, next slide. Okay, so when the pain of biliary colic persists over like more than 6 hours, we start to think of other differential diagnoses such as acute cholecystitis. So acute cholecystitis, from the name, it's an acute inflammation of the gallbladder due to obstruction, typically due to cystic duct blockage, or it can also be due to impaired emptying of the gallbladder. So the pain in cholecystitis is is similar to the quality and location of the pain in biliary colic, meaning that it's in the right upper quadrant, severe and sharp pain. However, it lasts longer and it can be more severe than the pain in biliary colic. And patients may also complain of radiation to the right shoulder or the scapula. That's the referred pain. Apart from that, they can have anorexia, nausea, and vomiting, bloating, and in contrast with biliary colic, patients with acute cholecystitis are systemically unwell, meaning they have fever as well. Just to note that in elderly patients, especially diabetic patients, they may just present with non-specific symptoms such as vomiting, nausea, lethargy, fever, and so on. So we need to be aware of this when treating elderly patients because they can just go on to develop complications straight away. Okay, so on examination of patients with acute cholecystitis, they're systemically unwell. They can have fever, be tachycardic, and they will have tenderness at the right upper quadrant and involuntary guarding because of the pain. And we may also be able to palpate a gallbladder mass, which is tender. And the typical Murphy sign may be present, which is inspiratory arrest on depopulation of the right upper quadrant due to the inflamed gallbladder hitting on the examiner's fingers. Okay. So, for the investigations in acute cholecystitis, we can do a full blood count. This is which will typically show an elevated white blood cell level, and liver function test also will show elevated liver enzymes. We should also do a serum amylase or lipase to rule out pancreatitis because the presentation is quite similar. And in the first line investigation, which is the ultrasound, we'll be able to, apart from the stones, we'll be able to see distended gallbladder with a thickened wall with pericholecystitic fluid collection. These features are very suggestive of acute cholecystitis. And just to note that sometimes stones may not be found on imaging. So in this case, uh, uh, this is called acute acalculous cholecystitis. This only happens in like 5% of the cases. Next slide. Okay, so in this is a trans-abdominal ultrasound picture. I think you can see it quite clearly. There is a gallstone there, a big gallstone at the gallbladder neck at the left lower corner of the picture with the posterior shadowing. You can also see the level of biliary sludge and the wall seems to be thickened. This is very typical of acute cholecystitis. Okay, so for the management of the condition, apart from supportive care like analgesia, fluid correction, low fat diet, the patients will usually need antibiotics and cholecystectomy at some stage. So cholecystectomy, again, like in biliary colic, early cholecystectomy is preferred. But in the case where a patient is unfit for surgery or cannot undergo surgery for whatever cause, we may do a temporary percutaneous drainage of the gallbladder to relieve the symptoms. Okay, so patients should also be monitored for complications. So, for example, if the patient presents complaints of worsening abdominal pain, high-grade fever, and chills, and symptoms of peritonitis, then we have to suspect complications such as gallbladder empyema when there is pus in the gallbladder, like abscess formation. And then when this happens, the a certain localized part of the wall can become necrotic, causing perforation, and this perforation can cause generalized peritonitis. In certain conditions, when there is very severe edema of the gallbladder, the wall can become gangrenous and the whole gallbladder becomes gangrene. But this is a very rare complication. Okay, next slide. So I just included some guidelines. These are the Tokyo guidelines from 2013 and 2018. They have several diagnostic criteria which will give you a suspected or definitive diagnosis of acute cholecystitis. It's very similar to what I explained. You can read through it later. They also have severity gradings where the acute cholecystitis can be graded 1 to 3, mild, moderate, severe, depending on the level of presence of organ dysfunction. And each of these grades have different algorithms for the management, like how early the cholecystectomy has to be done and so on. You can go through it later. Okay, next slide. Oh, okay, so I think we're all familiar with this image. It's about the bilirubin metabolism pathway from our Lippincott biochemistry book. I'm going to be talking about obstructive jaundice after this, so you can just read through this later to recap. Next slide. So jaundice, as we know, there can be prehepatic causes such as hemolysis and intrahepatic because of liver parenchymal disease, or posthepatic. Posthepatic is the obstructive jaundice, where there's an obstruction to the passage of conjugated bilirubin from the liver to the intestine. Next slide. So there are several ways to categorize. For example, you can categorize it according to the anatomy, the location of the obstruction. So it can be extraluminal causes such as malignancies of the liver or the head of the pancreas, any lymph nodes, for example, lymph nodes enlargement. It can be intramural, usually due to strictures, either benign or malignant, and it can be, intramural, or it can be intraluminal, which is the most common cause is gallstones. We can also divide the causes of obstructive jaundice into benign and malignant causes. Okay, next slide. Okay, so I got this table from a study that was done in a teaching hospital on several obstructive jaundice patients. So this shows you the percentage of clinical features in benign versus malignant disease. So we all know the features of obstructive jaundice, such as pruritus, dark-colored urine, clay-colored stool, and so on. And depending on the pathology which is causing it, because obstructive jaundice is not a definitive diagnosis, we need to find out the underlying cause. So depending on that, they will have other symptoms such as abdominal pain and so on. Okay, next slide. As for the laboratory investigations in obstructive jaundice, so in the liver function test, we will usually see that the direct conjugated bilirubin is raised rather than the indirect. And also, the ALP levels will be more than 3 times the normal upper limit. So yeah, and in urine analysis, we can see the presence of urine bilirubin, but no urobilinogen. And we have to send for coagulation factors as well to assess the liver function. And we can see elevated prothrombin time. Next slide. Okay, so this is just an algorithm of how to investigate patients with presenting with obstructive jaundice symptoms. So usually the first line is ultrasound, and in ultrasound, depending on whether we see bile duct dilatation or not, we can do the different procedures based on what we suspect. So these investigations will be further explained in the next part. So I'll just leave it to them. Okay, next slide. I think yeah, that's it from me.
Okay, Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. So let's continue our presentation today with I'll be presenting about ascending cholangitis, followed by gallstone pancreatitis and gallstone ileus for the differential diagnosis of gallstone disease. So firstly, ascending cholangitis. So ascending cholangitis is a clinical syndrome that is characterized by the Charcot triad, which consists of fever, jaundice, and right upper chondral pain. So that develops as a result of stasis infection in the biliary tract. So the causes of stasis in the biliary tract may include biliary calculi, benign biliary stricture, and malignancy. There's also like a severe form of ascending cholangitis, which is known as that could present as Reynolds Pentad, which include the three features of Charcot's triad, plus confusion and hypertension. So for ascending cholangitis, we do for blood investigation, we do the full blood count to see the race of total white cell, blood CNS to see for any bacteremia, then CRP, liver function test to see for any race of ALP and bilirubin, and serum amylase to rule out any pancreatitis. So for imaging, we'll do hepatobiliary system ultrasound to see for any dilatation of the common bile duct and to locate for any stone, and ERCP act as a diagnostic and therapeutic if the cause of the ascending cholangitis is due to obstruction of bile duct due to the gallstone. So ascending cholangitis could be the complication resulting from the gallstone. Okay, next. Okay, this is the Tokyo classification for cholangitis. So this like helps in the diagnosis of ascending cholangitis, also to classify the disease into mild, moderate, or severe. So you looking at the left picture there, there's A, B, C. So this criteria is to help in the diagnosis of ascending cholangitis. So criteria A is where it's the presence of system inflammation, followed by B, cholestasis, and C, imaging evidence of ascending cholangitis. There's actually an algorithm how to manage ascending cholangitis, which is located in the next slide. I'll explain that after this. And then for the right picture over there, there's to classify the disease into severity, mild, acute, or severe. So for moderate, we look at the blood count, which blood investigations such as bilirubin and albumin. Okay, so for management, okay, next. So management of ascending cholangitis. So firstly, for the acute management, if the patient is presented with severe ascending cholangitis, maybe the patient is in shock. So we need to resuscitate the patient first, and then followed by giving empirical antibiotics, antipyretics, and analgesia. And then look at the algorithm over there. It's actually quite small, but you could zoom in later. So I've mentioned previously that there is the criteria A, B, and C. So firstly, we have to confirm the criteria A for inflammation, whether there's fever, elevated white blood cell, and then C for if there is any presence of criteria B and C. So if there is criteria B and C also, one or more criteria of box B and C fulfilled, it is a definite ascending cholangitis. Whereas if there is one or more criteria of box B or C fulfilled, it is a suspected ascending cholangitis. So based from the Tokyo classification, we could further divide it into like grade 1, 2, and 3. So for grade 1 and 2, it requires like for surgical treatment, it requires biliary tract decompression, either from percutaneous transhepatic biliary drainage or ERCP, or definitive is cholecystectomy. So for 1 and 2, we could actually delay the biliary tract decompression. However, for criteria grade 3, which is severe, we really need to, in a emergency, we need to do immediate biliary tract decompression. Okay, next. Next is gallstone pancreatitis. So this is I think we've already discussed in the previous CPC about acute pancreatitis. So just a bit of recap. So the gallstone pancreatitis is gallstone is one of the most common acute pancreatitis causes in the West. So how acute pancreatitis happen due to gallstone? It is like the reflux of bile into the pancreatic duct due to transient obstruction of ampulla during passage of gallstone, or obstruction at the ampulla secondary to the stone, or edema. So basically, gallstone epicondyle is could be also due to gallstone is the complication of gallstone. So for the history for gallstone it's similar to acute pancreatitis, such as the patient presented with epigastric pain, which the pain radiates to the back, and then pain relief by leaning forward, typical of like which is called pancreatic positioning. So it is more similar as acute pancreatitis, nausea and vomiting, and also we have to look for signs of obstructive jaundice, such as jaundice, and then the fecal urine, and so on. And also for physical examination, there's also if the pancreatitis is hemorrhagic type, the patient could present with retroperitoneal hemorrhage signs such as Grattan sign and Cullen signs. So for investigation, we like because the patient presented with epigastric pain, we have to rule out for acute MI. So we do ECG, impaction of stone and pancreatic inflammation, and ERCP for diagnostic and therapeutic. Before we continue the presentation further, I think we should change the link because the time is almost up. Okay. One is here. Okay. Some more. Okay. So next slide. So how to manage gallstopancreatitis? Firstly, we have to divide into acute management and definitive management. So it is similar to how we manage acute pancreatitis. So firstly, we have to like the patient requires resuscitation. We do to resuscitate the patient and pain management, and then we follow like I've mentioned earlier the Glasgow criteria to determine the severity of the acute pancreatitis. If it is more than 3, it is indicated as severe pancreatitis. So the patient had to be admitted to ICU. So some of the criteria of Glasgow criteria include the age, more than 55, white blood cell, more than 15, blood glucose more than 10, LDH, serum urea, serum oxygen concentration, calcium, and serum albumin. So the definitive treatment is we have to manage the cause of the acute pancreatitis. So in this case, which is the gallstone, so we have to remove the gallstone, which is by ERCP or do cholecystectomy. Okay, next. Okay, lastly, gallstone ileus. So gallstone ileus is a mechanical bowel obstruction due to impaction of a gallstone in the ileum after being passed through a biliary enteric fistula. So for gallstone ileus, it is intestinal obstruction due to the gallstone going into the intestinal tract, going into the small intestine. So because of the gallstone enters the intestine through a fistula connecting the gallbladder with the duodenum, so as in the picture, forming a cholestoenteric fistula. So when the this is mainly gallstoileus, maybe because of the recurring cholecystitis causing chronic inflammation, which forms the uh, pathological fistula, which forms the fistula. So when the gallstone enters the uh, into the intestine, it will cause obstruction called the tumbling obstruction, where there is episodic subacute obstruction. So when there is an episode of intestinal obstruction, it will cause symptoms of intestinal obstruction such as diffuse abdominal pain and vomiting. After for a while, the pain subsides, and then the intestinal obstruction comes again. This is because of the term tumbling obstruction, where the gallstone tumbles across the intestine tract. So when it gets stuck, there is intestinal obstruction, and then the patient might, because of the vomiting and all, the patient might appear febrile and dehydration, followed by abdominal distension, increased bowel sounds, which is typical of intestinal obstruction. However, in gallstoileus, the jaundice is uncommon, which is about less than 50% of cases of gallstone ileus. So what we do to investigate gallstone ileus, we do a blood test to see for any elevated aminotransferases and imaging, which helps in the diagnosis in gallstone ileus, either to CT scan or X-ray. We could see features of Wigler's triad. Wigler's triad consists of pneumobilia, small bowel obstruction, and ectopic calcified gallstone, as you can see in the picture of the CT scan below. So pneumobilia is termed as presence of A uh, from the labeled picture there. It is a presence of air inside the biliary tract system. So which indicates that there is a presence of connection between the biliary tract and also the intestine, duodenum. So which indicates there is a fistula. And then for B is a small bowel obstruction. You can see that there is dilatation of the small bowel feature dilated, and then ectopic calcified gallstone C, as you could see properly there. There is around at the C area over there, there is calcified, which means the rim of the surrounding of the gallstone is calcified, so indicating a stone. So for management of gallstone ileus, we have to first, which is principle consists of three, where we enterolithotomy, where we open the bowel enterotomy to remove the stone, and then cholecystectomy to prevent recurrence of gallstone ileus, and to close the fistula, which is biliary enteric fistula closure. Okay, next. And that's all for differential.
Okay, Assalamualaikum. I am Aida. So I'll be presenting regarding the management together with Ines. Okay, next slide. Okay, so first is hepatobiliary ultrasonography or HBS ultrasound. So it is used for diagnostic purposes because it can inspect the gallbladder, its wall, as well as its contents, whether there's presence of gallstone, for example. So it can identify the dilatation of the intrahepatic and as well as extrahepatic biliary tree and the level of obstruction. And it can identify the cause of obstruction, whether there is gallstone or stones in the CVD. So from the picture on the left side, there is a hyperechoic feature of a gallstone, and you can see and you can appreciate the acoustic shadowing there. Okay, next slide. Okay. So next slide is ERCP or endoscopic retrograde pancreatico cholangiopancreatography. So ERCP can be both diagnostic as well as therapeutic. So for diagnostic, it visualizes the biliary tree as well as the pancreatic system. And for therapeutic, it can relieve biliary obstruction by removing CBD stones by sphincterectomy or end stone extraction. So ERCP can also do endoscopic balloon dilatation of the biliary sphincter using balloon catheters as well as stent placement to decompress the bile ducts. And then, however, ERCP it can lead to a few complications such as pancreatitis because there's irritation of the pancreatic duct due to the injection of the contrast, and then infection such as cholangitis, and then hemorrhage from the sphincterotomy, and then perforation of the duodenal or biliary tree. So the picture on the left, it shows a gallstone in the common dilated CVD, as well as GB, which is the collection of the radio-opaque gallstone in the gallbladder. Okay, next slide. So next is MRCP or magnetic resonance cholangiopancreatography. So it is a non-invasive modality that provides excellent imaging of the gallbladder and biliary system. So it can outline the morphology of the biliary tract and can also reveal filling defects that is caused by stones. And it can identify bile leaks, gallstone in the dark, and duct obstruction. However, MRCP is only for diagnostic. It is not therapeutic because no intervention that can be performed. So if we were to compare MRCP and ERCP, MRCP shows clear image of the biliary tract, but ERCP is much better because it can visualize the biliary tree as well as therapeutic interventions can also be done during the process. So from the picture on the right, there is a small calculus C in the distal common bile duct. Okay, next. Okay, so next is percutaneous transhepatic cholangiography and biliary drainage, PTC and PTBD. So PTC is done when ERCP is not feasible to be done or if it is unsuccessful. So from the picture on the left, so that is how the procedure is done, in which there is a long fine needle that is passed percutaneously directly into the dilated intrahepatic ducts, and then contrast is injected to display the duct system. Okay. And then PTC, it can show the configuration of extrahepatic duct obstruction from the proximal direction, and it can drain obstructed ducts after failed endoscopic placement of a drain or a stent. So PTBD, it includes insertion of a temporary catheter to drain the bowel through external or internal external drainage. Okay, next slide. So for intraoperative cholangiography, so it is a standard practice to perform during open cholecystectomy, where there is a fine plastic cannula that is introduced into a small cystic duct incision, and it is passed into the CBD. And then contrast is injected to outline the duct system, and fluoroscopy images or X-ray films are taken. So if there is duct stones demonstrated, then they can retrieve it surgically at the same operation. So intraoperative cholangiography, it allows biliary anatomy to be displayed. It can demonstrate stones in the bile ducts, and it can show whether the contrast flows freely into the duodenum or not. So from the picture there, okay, there is a small radiolucent calculus present at the lower of the CBD. Okay, next slide.
Okay, Assalamualaikum. My name is Ines, and I will continue with the last part of the presentation, which is the treatment part of the management. So for the treatment part, we have the non-surgical and surgical management. For non-surgical, we have the oral bile acid dissolution therapy and also the percutaneous cholecystostomy and gallstone extraction. And for surgical, we have the cholecystectomy and also the CBD exploration. So next. So for the oral bicep dissolution therapy, the aim is to reduce the severity of the symptoms, clear the gallbladder of stones, decrease the risk of gallstone-related complications. So the choice of drug is the ursodeoxycholic acid or ursodiol. So usually we give 10 milligram per kilogram daily, BD or TDS. So this one is usually for the cholesterol gallstone because it can solubilize the cholesterol. And for additional medication for the pain control, such as the biliary colic, we can give NSAIDs like ibuprofen or opiates such as morphine. So next. And next is percutaneous cholecystostomy and gallstone extraction. So this one we use in patient high risk for cholecystectomy. Usually this is performed 2 weeks or more after placement of the cholecystostomy. This is to create a fistula before we inserted the basket to remove the gallstone. So who is the patient with high risk cholecystectomy is patient with liver cirrhosis or the patient with more than 65 years old and also pregnant patient. Next. And so we move on to the surgical management, which is the cholecystectomy. So it is a gold standard. It has laparoscopy and also open. So the indication for cholecystectomy is to if a patient has symptomatic gallstone disease or asymptomatic gallstone, when there is a reasonable likelihood of future symptoms or complication. So for absolute contraindication, if the patient is in late stage of the pregnancy or if patient has uncorrected major bleeding disorder. And there is also relative contraindication, which is morbid obesity acute cholecystitis, untreated bile stones, and intra-abdominal malignancy. So as the previous presenters has already said this before, so the aim of cholecystectomy is to prevent future attacks of the biliary colic and also to prevent the complication of gallstone disease as well as to prevent recurrence. So next. So this is the principal step in cholecystectomy. So first we must cut the cystic artery first that supplies the gallbladder, and then we make the junction between the cystic duct and common bile duct. And after that we incise the cystic duct, and then we stump the cutting site. Okay, next. And then there is several condition which the laparoscopic cholecystectomy can be turned to open cholecystectomy. So this is what I found from a study. So if there is severe adhesion, which the patient have done other operation before, and that cause the severe adhesion, and also if there is intraoperative hemorrhage, so laparoscopic is hard to visualize inside the peritoneum, so we must convert to open cholecystectomy. And if there is bile duct injuries and also cholecystoduodenal fistula. So below is the potential complication of the laparoscopic cholecystectomy. So you can see it can be divided into the during operation, post-operative, and also late complication. Okay, next. So this is just the algorithm of how we manage the gallbladder, and you can read it later. Next. So next we have this common bile duct exploration. So the common bile duct exploration, we have two approach, which is the transcystic approach and also the chorioidocotomy approach. For the transcystic approach, it is we make a incision in the cystic duct, while the chorioidocotomy, we make incision in the common bile duct. So usually for transcystic, we use in if the CBD diameter is less than 7 millimeter, and also the stone location is distal to the cystic duct or the CBD junction, and the cystic duct diameter must be more than 4 millimeter, and there is less stone, which is 6 to 8 stone in the CBD. The stone is also have to be less than 10 millimeter, and lastly if, the lateral entrance of the cystic duct to the CBD. And for chorioidocotomy, we do if we fail the laparoscopic transcystic exploration or the preoperative endoscopic stone extraction. So we do this if there is narrow or tortuous cystic duct, and if the dilated CBD is more than 7 millimeter, and also if there is large stone, which is more than 10 millimeter. And also multiple stones, which is more than 8 stones, and the location is proximal to the cystic duct or the CBD junction, and lastly it is distal or posterior cystic duct entrance to the CBD. Okay, next. So this is the picture of the different approach. So you can see from the cystic approach, they make the incision in the cystic duct, which they will flush the solution and cause the stone to be dislodged into the duodenum. And for the chorioidocotomy, you made the incision in the common bile duct. And then for chorioidocotomy, they will insert a T tube in the picture right below for the any remaining stones to be extracted as well. So I think that's all for the presentation.
Alright, can go back to this from the start. Okay, next. Okay. Uh, Go to the differential and provisional diagnosis. Okay, so in provisional diagnosis and differential diagnosis, there are a lot of things that you can justify whether you want to decide it is differential or provisional diagnosis. What you have been mentioned just now is not enough. Okay, for example, like evidence of epigastric pain. Okay, the justification is not strong. You need to have in detail. What about epigastric pain radiated to the apa, right hypochondrial region and to the back? That one is also justification to show that it is more like biliary colic symptoms rather than other other problems with regards to epigastric pain. Um, so you need to be more specific, or else it is no point for you to ask further about the characteristic, but you not include in the justification for the provisional diagnosis and differential diagnosis. So you need to have a detail on the character of the epigastric pain to show that it is more likely on the like what diagnosis that you put in the provisional diagnosis rather than differential diagnosis. It is not like you want to put the ask further about the the character of the pain, the detail about the pain. At the end, you not use it as a justification for or point towards your provisional diagnosis or justification to exclude your differential diagnosis. There is like wasting time lah, wasting time. You are asking the patient, you are utilize your time. At the end, you don't use it for your point towards your analyze and giving out the diagnosis. Okay, so next. Okay, next. I hope that you know for the investigation. Okay, I always emphasize for the year 3 and year 5 student. Go back to the previous slide. Okay, you need to know what is the purpose. What is the purpose to get in the liver function test? What is the purpose? But this is okay if you not write it in the presentation. But I hope you know what are you looking for on this kind of investigation that already been taken, as well as the features that you want to look for in ultrasound HBS. Okay, because this is more like case presentation, so it is okay. But as a principle, you need to know the purpose why we get in the liver function test. Okay, so I don't want to elaborate more about that. I think you have been covered these things maybe in your year 3 or in the seminar. Okay, next. Okay, this is an example on how we treating patients with polydoccolitiasis. Okay, next. Okay, for the anatomy and physiology, uh, basic things about anatomy. Next. Previous slide. Wait, lagi. Lagi previous slide. Anatomy. No, the previous slide about the anatomy. Okay, relation. Okay, um, okay, the other things that I want to emphasize is about the layers of the gallbladder. In what is the I mean, the histology part of gallbladder is also important for you to know. Histology and layers of the gallbladder. Okay, next. And then the relation of the biliary system towards other part of structure, especially the content of portal hepatis, okay, which is consists of bile duct, portal vein, as well as common hepatic artery or hepatic artery proper. And then you need to know the position and what is the significant relation with the lesser sacs. What is the lesser sac? All of this is a surgical significance of the anatomy of biliary system. And there are anatomy that you needs to know, which is the anatomy of the celiac artery, the branches of celiac artery, and how does it distribute towards branches, especially after the celiac artery uh, diverse into three things, and then what after that at the level of hepatic artery proper, what is the branches is looks like. Because whenever I ask students about this, they will confused and not knowing of the celiac artery structures. Okay, they only know about the branch at the level of biliary system, but they doesn't know about the branch over the origins of celiac artery. Next. Okay, next. Okay, the physiology is not enough. Physiology, you need to know about the bile secretion, okay, and then the bile composition, as well as the lipid absorption and the role of bilirubin. Bilirubin hepatoenteric circulation of the bile. Okay, that is what uh, what things that you need to know about the physiology. First is the how the bile is secreted, kan? Bile is secreted, and what is the how does the bile secretion controlled by our system at the sphincter of Oddi. What is the stimulation that control the relaxation and contraction, as well as the contraction of the gallbladder. And then the next thing is enterohepatic circulation of the bile. So this is important. What is the role of the bile? And in general about secretion, how many bile has been secreted per day in normal adult population. So that's all. That's about the physiology of um, biliary system that you need to know. Alright, so with regards to gallstone, okay, next. Okay, next. Okay, for the next. Okay, basically to differentiate between gallstone, there will be cholesterol stones and also pigmented stones. And then in pigmented stone, there will there are black pigment and brown pigment. Black pigment is due to over saturation of bilirubin. Okay, and they will mix with calcium, thus the color will be presented as a black pigmented. However, in brown, usually it is related with the infection. So what types of bacteria that is commonly associated with brown pigment stones? That one you need to know the common bacteria that causing cholangitis. Next. Next. Okay. So you can look at the features. Okay. I think you need to look in the other sources on how does biliary colic is defined. Okay. This is a part of type of biliary colic. When we ask about how can you define that this presentation is biliary colic or not, so you can define it by what the character of the penis looks like. So that is my point lah, about the clinical features, which means that you need to highlight that this type of pain in this patient is more like a biliary colic pattern of pain. Why? So you can describe it. Okay. Sometimes the character of the pain from the patient is not absolutely typical like biliary colic features, but it is okay because we just want you to know that you can able to highlight or define that this type of pain is biliary colic or not. So how do you do that? You can show it from your clinical presentation. From your clinical presentation, you showed that this type of pain is a biliary colic pattern. Okay, and then we supported by other things. Okay, for example, like patient with have sort of obesity, or patient 40 years old, female. That is the point that can support your justification to show that this is more likely likely gallstone disease rather than other type of disease like gastritis or gastroesophageal reflux disease. Okay, next. Okay, another things that is important, because as a medical student medical student level, I want you to emphasize more about the definition. Okay, the definition. Um, like what I've said just now, the definition of biliary colic. What is the exact define of biliary colic? The second thing is what is the definition of Murphy science? Okay, in malignancy, like what is the Coverse's law? You need to define it and understand it, and can able to give a definition, correct definition. The one way that you can uh, uh, successfully define it is by memorize it. Okay, But the other way that you can do is you define it multiple times, okay, read it multiple times, and you can able to explain it to your other colleagues, the definition, until your colleague understand about it. So means that you already know about that kind of definition. Okay, next. Okay, for the acute cholecystitis, okay, like what you said just now, the supportive management is to give an opioid analgesia. Giving analgesic to the patient is more like same in general. You need to give it. The principle is that you need to give it according to step ladder of principle in giving analgesic. It's not like you straight away start with the opioid analgesia. Okay, then the other things is low fat diet. For if we talk about the acute cholecystitis, of course we want to focus on how to give a supportive treatment at that time of presentation. Patient came to you with a problematic symptoms, okay, you want to alleviate or relieve the symptom first. So if you said that the supportive management is for the patient to avoid low fat diet at that time, I think it's not correct lah. Okay, patient came to you at emergency department, I have got the pain, right upper neck pain, and you diagnose patient with acute cholecystitis. Then you said, I think you said to the patient, I think you have acute cholecystitis. So I will give you paracetamol with NSAIDs to relieve your pain. Okay, that's okay. And then you need to avoid low fat diet. You just straight away said, patient came to you with pain, then straight away you advise patient to reduce the fat diet. Okay, this supportive treatment, okay, okay, I give you the correct definition. Okay, okay, so the flow is like this. When patient came to you with certain type of problem, the supportive treatment is for you first to give whatever treatment that can alleviate or relieve the symptoms before you treat the patient with definitive treatment. Second, you are expected the complication that might rise towards that kind of disease, and you want to prevent further complication that can exist or can occur if before you give a definitive treatment. That is supportive. Or in situation like patient that have a disease that is untreatable, okay, or incurable. So you want to give supportive, or what we call it as a palliative treatment, to make the patient more ease, to make the patient more comfortable from what condition that patient have currently. Understand? And then there are sort of a supportive treatment, but we don't call it as a supportive, we call it as a preventive. Okay, preventive approach to avoid or um, to avoid the disease to recur again after the treatment, for example. Okay, that we call it as a prevention. Or patient that have a risk to get certain disease, we want to reduce the the risk, reduce the risk or outcome of certain disease. So we call it as a preventive measures. So you need to be more careful about the definition. So the supportive management, okay, I can give you example. For example, like patient in malignancies, we give a DVT prophylaxis as a preventive because we want to avoid deep vein thrombosis or any thrombosis related event to the patient upon admission. So or we can give a nutrition. Okay, that's all. We call it as a supportive treatment or supportive measures. But then for the low fat diet, is more like you want to prevent further further recurrence of that kind of disease. It's not the low fat diet. It's not like you can treat the treat that kind of current disease to at their own and at the sudden onset at the if you avoid the low fat diet, then patient straight away can relieve the current symptom kan. It's not logical to give that things. Okay. I think this statement, it is because you are giving the point that include in the textbook, but you don't understand about the context. Okay, but for me, you need to be more careful about the definition and treatment because it can give a wrong perception towards your other colleagues. Okay, in the exam later, if your colleague said about this, I think it is quite weird because giving low fat diet does not relieve the condition of the patient at the current state if the patient have acute cholecystitis. Okay. Okay, so I think you have been mentioned about the treatment of the acute cholecystitis. Nowadays, I agree that we have more towards defining cholecystectomy in early early state of acute cholecystitis. In traditionally, we are more towards giving cholecystectomy at a delayed onset after 6 weeks when the inflammation has been subsided. Then we offered patient with cholecystectomy. However, nowadays there are some evidence that show that it is doable to do an early cholecystectomy. That's why we are towards more into the early cholecystectomy approach rather than delayed cholecystectomy. In certain condition where the patient has unstable, not fit for cholecystectomy, or patient that have features of gallbladder empyema, one of the approach is percutaneous cholecystomy. This is only for those who are not fit for surgery. Okay, unstable patient, not fit for surgery, contraindicated to do surgery, we can offer it percutaneous cholecystectomy. However, patient needs a definitive treatment, which is cholecystectomy once patient has been cleared from the contraindication that patient have during the cholecystostomy, because that is the definite treatment for acute cholecystitis. However, there are some situations that we are not offering patient with cholecystotomy if the patient has an absolute contraindication towards operation in general, like myocardial history of myocardial infarction and so on. Okay, next. Next. Okay, the Tokyo guideline. Okay, first, the Tokyo guideline mention about the diagnostic criteria to diagnose acute cholecystitis. Second, mention about the severity that we can classify acute cholecystitis, and then the treatment approach according to the severity. So that is the what Tokyo guideline state in the guideline. Okay, next. Okay, this physiology is important for you to this is the cycle of the bilirubin. Um, the another important thing is on how the bile is absorbed into the circulation from the fat absorption with regards to bile facilitation. Okay, next. Okay, next. Okay, next. Okay, the other things that you next. Next. Okay, another things that you need to know about the obstructive jaundice is what is the complication with regards to obstructive jaundice. Okay. And then the next thing is the pathophysiology on each symptoms. Okay. For example, why does the obstructive jaundice exhibit as a scleral, yellowish sclera, pale stool, tea-colored urine, as well as an itchiness over the body. So how does all these symptoms can develop with regards to obstructive jaundice? Okay, next. Okay, sending notice. Okay, next. Okay, so Tokyo classification, there are guideline on acute cholecystitis as well as the guideline on cholangitis. Same, there are diagnostic criteria as well as severity criteria. Okay, and then treatment approach according to severity of the cholangitis. Next. Okay, next. So gallstone pancreatitis, the treatment is same like regular pancreatitis, acute pancreatitis. However, you need to know about the pathophysiology. Okay, so does the patient in gallstone pancreatitis necessary to do ERCP? Do we do ERCP in all patients with gallstone pancreatitis? The answer is no. It depends whether there is if there are features of obstructed system, then ERCP is indicated. However, If there are no other features on ERCP, on gallstone obstructed symptom, then ERCP is not indicated. There are other diagnostic modalities that you need to know, which is EUS, endoscopic ultrasound. It also can be used to diagnose features of biliary system and also the pancreatic duct. Next. Okay, next. So when you look at the management, okay, management of gallstone pancreatitis, go back to previous slide. Management is supportive management like regular pancreatitis, IV fluid, hydration, okay, resuscitation, alleviate the pain, and the definitive management is index cholesterol, in which we emphasize or we advocate to do cholestomy on same admission. And then you need to know what is the reason we need to do cholestomy on the same admission. You need to know what is the reason of that. Okay, next. Okay, next. Okay, next. We have 11 minutes more. Next. Next. Okay, next. This is about the general things about all the modalities that we have. Okay, next. Okay, for MRCP or ESCP, you need to differentiate on which one is which. Usually for modalities like MRCP, we are not really looking towards the things in gallstone via MRCP, because the visual is actually, for me, is actually CT scan, and ERCP is more clearer compared to MRCP, and it's quite difficult for you to get the MRCP. And usually in hepatobiliary, the MRCP is useful over two diseases. One is the um, pseudosis or IPMN in pancreas, and the second is choledochosis. That's two diseases that we usually require MRCP. However, in disease like gallstone disease, we rarely use MRCP as one of our diagnostic modalities. Next. Another modalities that you need to know is cholangioscope. Cholangioscope is used as an adjunct or as together with ERCP. So we use it. Uh, it can be used as a diagnostic as well as therapeutic. Or in Boston scientific companies, there are cholangioscope that we call it as a spyglass system. Okay, next. Okay, next. So you need to know about the cholangioscope lah. One of the modalities that we has been used nowadays. Okay. Okay, next. This one, it is good for you to know. For also the osteocholic, we rarely use to treat gallstone disease nowadays, because the absolute treatment for symptomatic or complicated gallstone is cholecystectomy and relieve the obstruction in the biliary system. That's all. Okay, next. Okay, next. Okay, next. Okay, next. This one is good for you to know. because in your exam we rarely ask about this sort of further treatment or techniques on cholecystectomy. What we want you to know is about the complication that might related during cholecystectomy. That one is also important. Okay, next. Okay, next. Okay, the complication with regards to cholecystectomy. Okay, next. Okay, this one is good for you to know. Next. Alright. So any question? If there is none, I think because we have a short time, any question that you want to ask, you can ask me through email or through WhatsApp in the later. Alright. Okay, and so for the wrap up, first about the Gallstone disease, there are a lot of diagnoses that can caused by the Gallstone disease. In your history taking and in your physical examination, first you need to able to define what is all the cholecystitis, what is cholelithiasis, what is cholelithiasis, what is costopancreatitis, and what is the features, what is this presentation. And at the end, you can apply it to your patient with details justification that what I have been emphasized uh, for you just now. Another thing about the how to get on the diagnosis, you need to know what is the modalities that we have, what we available, as well as laboratory investigation. You need to know each of the each of the um, disease or each of the investigation has its own purpose. Okay, for example, like renal profile, what is the purpose in condition like patient that have sort of Gallstone disease, what is the purpose of renal profile, coagulation profile. If you know about the pathophysiology, then you can know. Okay, I give you a clue. For example, in obstructive jaundice, one of the complication is a liver failure that can lead to hepatorenal syndrome. So, what is the hepatorenal syndrome? What is the pathophysiology behind that? And what is the features in the patient that have the hepatorenal syndrome. Okay, in the patient with liver failure, other features that we want to look like albumin, like child score, albumin, apa tu, coagulation profile and so on. Okay, the next thing is treatment. The treatment can be expectant management or supportive management and definitive management. So you need to know, for example, like for this patient, I want to give the antibiotic. Why? For this patient, I want to give the hydration. Why? For this patient, I want to give analgesic like that. And then the definitive management for this patient is surgery, which is I want to do. This patient is will need CBD exploration, ERCP ke, cholecystectomy ke, or percutaneous cholecystotomy. And then because this and this. Percutaneous cholecystotomy because patient has contraindicated to do ni. Macam tu lah. Okay. And then for you, that is the end outcome lah. For you to know, but all first start with know how to define certain things. Okay, know how, and then know about the pathophysiology of all the things, symptoms that have been mentioned. So you need to know why does the patient can exhibit on this sort of symptoms. What is the pathophysiology of that? So that's how it can be applicable to other diseases as well. So that's how you can get to know about certain disease in general. Okay, so I think we can end of our session today. Okay. Um, if you have any doubt, any question, if we can meet again later, or because this week dah already exam kan, so if you have anything, you can ask via WhatsApp lah. Okay. Okay. Thank you.
Thank you, Mr.
Thank
Thank
you,
you, Mr.
Mr.